Hello. We are pleased today to host an update on the Pediatric Developments panel associated with CROI in Seattle in 2017. I'm the host of the panel, and I have a distinguished group of speakers and presenters from the conference with me. We are grateful for IFARA to give us this opportunity to update you on the new science, new developments that are related to the pediatric diagnostics and treatment in HIV. My name is Natella Rachmanina, and I'm a professor of pediatrics at George Washington University in Washington, D.C., and I also work as a senior technical advisor to the Elizabeth Glazier Pediatric AIDS Foundation. With me in the room, I have three distinguished speakers, and I will pass on now the word to each one of them to introduce themselves, and we will start our panel. Please, Hermione.
My name is Hermione Lyle. I'm a paediatrician from London. I work at Imperial College Healthcare NHS Trust, and I've been involved with looking after children with HIV for the last 20 plus years.
Thank you. I'm Jintanad Ananwaranich. I'm a pediatrician, and I'm Associate Director of Therapeutics Research at the U.S. Military HIV Research Program.
My name is Bindia Mekji. I'm a researcher at Instituto Nacional de Saúde from Mozambique, and I currently work with point-of-care technologies, especially for early infant diagnosis.
Okay, great. Thank you very much. And we have a great expertise of people who can talk today about all the spectrum, anywhere from issues of cure, which I hope we can touch on, and potential for cure for children and infants, to the diagnostics of HIV in a timely manner, and to the treatment option of treating children who unfortunately have infection and we were not able to prevent it before we diagnosed them. Let me start with Hermione and ask you about your impression of this conference focus on the pediatric treatment. Where do you believe at this conference the major focus along the pediatric treatment has been placed? Hermione.
So we tried very hard for this conference to make the main focus around about infants. So looking at the unfortunate situation where we haven't been able to prevent transmission, then how can we diagnose babies as soon as possible? How can we get them onto treatment as soon as possible? What are the most efficacious treatments? What's the best way to test them? How can we support families, and all the kind of social elements around the treatment? And bearing in mind all the evidence that we're gathering about early treatment and how that might lead to a better chance of remission, I think this is a really important focus.
And by remission, what do you define the concept of remission of treatment? I believe until now...
I might pass that question on to my colleague here.
Okay, give us an idea, because the remission is frequently in general knowledge is associated with diagnosis like cancer.
Yeah.
And here we are talking now not just a lifelong treatment, what Hermione just highlighted, but remission for HIV. What could you explain us where the focus is there?
So in HIV cure research, we talk about remission and eradication. And remission is when people can have undetectable viral load in the blood without taking antiretroviral therapy for possibly at least 12 months. And so they still have HIV in their body, but they can control it to low levels. And so that's one of our goals in the cure research field. And that's a more near-term goal, and our ultimate goal is to eradicate HIV from any cell in the body.
Is there any difference about approaching the remission and generating the remission in young infants, since there is a focus on early treatment compared to adults? Could you highlight this difference for us?
Yeah, I think, in both populations, we want to diagnose and treat as soon as possible. In children, though, we have a very unique opportunity because the transmission is at birth in most infants. And so in contrast to adults, sometimes it's hard to diagnose as early as possible. In infants, we have that opportunity. So I think that really distinguishes the two populations. And if we can bring other types of testing in so that we can immediately transition from ARV prophylaxis to treatment, and we know that if we can do that as fast as possible, we can really have very low reservoir.
You pointed out to the issue of knowing diagnosis right away. And there have been challenges around that in resource-limited settings about the timely knowledge of the diagnosis in young infants. We have today's speaker who presented, Bindia, you presented a study from Mozambique yesterday. Could you please talk about your view overall on the challenge of timely diagnostics to which Jinda just alluded, and what is your study highlighted?
Okay, so the main issue in resource-limited countries is that the current conventional lab testing system has many logistic problems. That's why only 50% of the kids receive their result within 2 months of the collection in all the priorities countries, according to WHO. And the main logistic issue are because this testing is centralized. We have a referral sample system, then you have lost samples, lost results, and kids can die before they receive their own results. So we conducted evaluation of a point-of-care device to show their performance, and we show that the technology has a very good performance compared to the lab testing, lab technologies. And then we move forward to a cluster randomized trial that is a study to show the use of this point-of-care device and to show their impact in clinical outcomes of the children. And we did these studies with 16 health facilities in Mozambique, from which 8 health facilities use this point of care, and the other 8 facilities use their lab conventional system. And our main results were that our intervention arm had 7 times more kids on treatment within 2 months compared to the standard of care. And also we have more 20% of kids that were retained after their treatment started during 3 months of follow-up. And the main advantage is that the turnaround time of the result was 0 days in the point of care compared to 125 days in the lab system. So that is very important to put these kids in treatment as soon as possible compared to waiting 127 days, and they can die during this period, and they are lost to follow-up as well.
I think it is particularly remarkable in your study that not only you were able to initiate them on treatment, but it looks like your retention on treatment has been better. How do you explain that?
There can be that normally when you come to the health facility and you don't have your results, you come the next month, you don't have your result, so you start losing faith on the health system. So because in the point of care arm, the results were available on the same day, that might create a better relationship with the health facilities, and they were more retained. As well, from the health professional side as well, as they are also happy to give the result as soon as possible, they would be giving more attention to the patient, and that's why the relation is better and they can be better. But it's just scenarios that we think that can happen.
When starting the treatment at this young age, do we still have any barriers to actually doing it in an efficient manner?
Well, I think that's a very important point. And Louise Kuhn, who also took part in our session yesterday, presented data on roughly 100 babies from Johannesburg in South Africa. And she particularly looked at the babies who had been started on treatment at less than 15 days of age. And even in the group of babies who've been started on treatment in the first couple of days of age, there were still 3 of them who died before a few months. And this is such a high-risk time of life. These babies are so susceptible to other infections. But even if you get babies onto treatment, it is very intensive. They need to be followed up very closely. They need to have their doses of medication increased every 3 or 4 weeks. The drugs are difficult to take, particularly lopinavir liquid or granules. They are not easy to swallow. And in their very closely monitored group, they only managed to get roughly half of the children to persistently undetectable viral load within 6 months. And that is, you know, that is not as good as we would like it to be. But from the point of view of what Jintanet was talking to us about, and about really getting effective and long-term suppression, there were, I think, a third of those children who actually had become DNA PCR in the cells negative, which means that their reservoir of virus detectable in the blood cells has become very, very small. And that's what we want to aim for. But we need better drugs. We need better regimens for small babies to get there. And there have been some presentations at the meeting about using, for example, getting pharmacokinetics for using integrase inhibitors and other formulations. And we need to be able to improve that for little babies.
Yeah, I mean, our experience from Thailand, we work with the national program to try to get kids into treatment as soon as possible. And, you know, there's about 100 children born in the whole country that's HIV infected per year. It takes so much effort to track each child, put them on treatment. And then we see the same thing as viral suppression rate is 50% at 1 year. And so it's really unfortunate. And it's really because we don't have good enough treatment options for this group.
And if I understand correct, just to clarify, those babies that will take longer time to become undetectable, in your view, from the point of view of remission, the chances for successful remission are less than those that become detectable early or not. How would you look at this prolonged time period?
I would say that's a bit tricky because we don't know what is the biomarker for remission.
Right.
But for reservoir size, that's true. If you take longer to get to viral suppression, you're likely to have a larger reservoir size. Whether that translates into time to viral rebound, it's different. We don't know that.
But I think there's another interesting point here, which is if you pick up a baby at birth who is HIV positive, although the baby might have been infected around the time of the delivery, it may also have been infected earlier on in pregnancy and might have already been infected for several months. And so then it's hard to know, actually, the timing. So I think as we have less babies who are infected around the time of delivery because of maternal treatment being given, and of those who are positive, more who have maybe been infected in utero, that also makes it a little bit more tricky.
Yeah. And that's really hard to tease out.
Yeah.
Do you have your dream regimen for babies yet available or not?
I don't.
In terms of
I would think
medications.
integrase inhibitor would be
Integrase inhibitors.
because it would be able to reduce viremia faster.
I think that's absolutely true. I think you need to have a regimen that is definitely very good at penetrating the CNS. You need to have something that is palatable. You need to have something that ideally, the less doses you need. It's got to be on the side of the mother. And it also has to be, you know, you can give it with food or without food. All of these considerations actually make a huge difference.
And supporting the mother in administering this treatment. That goes back to your study. How well was your staff involved with supporting the mothers, sending them home on treatment? Did you have any experience seeing that interaction grow as study went on?
Our study didn't focus on that area, but currently in Mozambique we are approaching the technique of giving the treatment by the nurse in the same consultation where mother and child are seen. So during our study this was initiated. So there was some difficulties in the beginning by the nurse to start giving treatment for so smaller babies, because normally they waited so many months so the baby were bigger, and now they were handling 1 month babies, and they had some issues and struggled to start the treatment. But then during the study they were more used to do that.
It became kind of hands-off experience for mom to learn how to do it and continue doing it at home.
I wonder the viral suppression rate in your cohort, how is that?
So we didn't measure that because this technology only says it's positive or negative. But maybe in future studies we can do that. Yeah.
But I think it's true, whatever can be done as a sort of one-stop shop is
Yes.
really important. So the mum can get her treatment, the baby can get their treatment, any support around the family in terms of nutrition, peer support. We find that whether there's other mothers who have been through the same situation and who can act as supports, that is enormously powerful.
That is absolutely the case. And I have treated children in a different rich settings over the years in Washington, D.C., and I can tell you that even with resources available, the components you outline now, they're crucial and they're very important, and you can't replace them with anything else. As we conclude the panel, I'd like each one of you to make a final statement about where do you see the future of pediatric HIV moving. And I believe you laid a lot of foundation for that right now, but just a few closing words from each one of you.
Well, I'm glad to see the number of children in my clinic going down because that means less babies are getting infected. I'm also excited to see young girls who are now in their 20s having babies of their own who are uninfected. So easier drugs and, you know, better life. It's the whole kind of 90-90-90. That's what we need.
Thanks, Hermione.
I agree. I think that we have such a unique opportunity to start treatment early, and hopefully we'll have better options for these children. And I think the awareness of the reservoir and all this perhaps in some ways has helped to get people more excited about trying to start treatment early and maintaining viral suppression.
Bindya, from the field.
I would say social aspects of all these issues are very important because even the option B plus is rolled out. We know in Mozambique, for example, the adherence is very low. Even for the treatment of the kids, they can stop because the father refused or the mother-in-law refused. So all the social aspect of these issues should be in consideration. Even if we have the best drug, it cannot do anything if we don't have all the aspects together.
Well, I want to thank you all very much for a very insightful summary of the current and future pediatric challenges, our successes and failures. I look forward for you to bring in more great science and great developments programmatic on the ground to our next conferences to improve the outcomes and survival and remission rates and future of children with HIV. And thank you very much.